Welcome to Surgery 101 podcast. We'll be talking about a pneumothorax, which is one of the commonly encountered clinical problems in a trauma and thoracic surgery. We'll be discussing the definition of a pneumothorax and its pathophysiology, classification of a pneumothorax, diagnosis of a pneumothorax, clinically and radiologically, describing the appropriate management of attention pneumothorax, traumatic pneumothorax, and spontaneous pneumothorax, describing the steps involved in inserting a chest tube. Pneumothorax is defined as the presence of air in the intrapleural space with secondary lung collapse. In order to appreciate the pathophysiology of this condition, we must first discuss the anatomy of pleural cavity. The thoracic cavity is lined by a thin double-layer membrane. The visceral pleura covers the lung and hiatal structures, and the parietal pleura, which covers the chest wall, diaphragm, and mediastinum. In a normal state, the pleural space is a potential space between the two membranes, containing a thin layer of lubricating fluid. This fluid creates a surface tension that keeps the lung in contact with the chest wall, allowing it to expand as the chest expands for ventilation. The presence of air in the pleural space disturbs the lung mechanics, resulting in a collapse of the lung. This lung collapse results in impaired ventilation on the affected side and potentially decreased oxygenation. Pneumothorax can be classified in two ways. First, a pneumothorax can be classified according to its cause. There are three major etiologies of a pneumothorax, which are spontaneous, traumatic, and iatrogenic. Spontaneous pneumothorax can be further classified into primary or secondary. In addition to classifying a pneumothorax by its cause, it's also important to describe a pneumothorax in terms of its pathological effect on the patient. In this respect, there are three main types: simple, open, also known as sucking, or tension. A spontaneous pneumothorax is the one that occurs in the absence of a precipitating event such as trauma. If it occurs in a patient with a healthy lungs, it's considered to be a primary spontaneous pneumothorax. Risk factors for spontaneous pneumothorax that occur primarily include thin, tall body habitus, male gender, and a younger age, typically 10 to 30 years old. Smoking is also considered to be a major risk factor. Other suggested risk factors include change in the atmospheric pressure, such as air travel, as well as certain genetic predisposition. In contrast to primary spontaneous pneumothorax, secondary pneumothorax present in older individuals, typically over the age of 55, with known underlying lung disease, such as COPD, asthma, cystic fibrosis, pulmonary fibrosis, sarcoidosis, neoplastic disease such as bronchogenic carcinoma and metastatic disease, infectious etiology such as TB, necrotizing pneumonia, pneumocystis jirovecii pneumonia, HIV, and parasitic infection. Other miscellaneous causes such as catamenial, Marfan syndrome, and anhedonis. COPD is the most common underlying cause of secondary spontaneous pneumothorax. It involves rupture of alveoli, which are large air-filled spaces within the lung. Iatrogenic pneumothorax can be caused by medical procedures such as lung biopsies, including both transthoracic and transbronchial biopsies, central venous catheterization, thoracocentesis, and pacemaker insertion. Another medical procedure associated with iatrogenic pneumothorax is mechanical ventilation. Positive pressure ventilation can hyperinflate and rupture alveoli, introducing air into the pleural space. This is more common in a patient with underlying lung disease such as COPD. A traumatic pneumothorax results from a blunt or penetrating trauma to the chest. Injury to the lung, thoracic wall, airway, or esophagus can result in air entering the pleural space. A pneumothorax with partial collapse of the lung, no other adverse clinical changes, is considered a simple pneumothorax. An open or sucking pneumothorax occurs as a result of a large open chest wound, where air directly enters the pleural space during inspiration as a result of a negative intrathoracic pressure. Attention pneumothorax is a life-threatening emergency that can occur with any etiology, including spontaneous pneumothorax. It occurs when a one-way valve mechanism allows air to enter the pleural cavity during inspiration, but not to exit during expiration. This results in the collapse of the ipsilateral lung and the compression of the contralateral lung. Ventilation is then impaired, resulting in hypoxia. Tension pneumothorax also results in the contralateral shift of mediastinum and compression of the superior vena cava, which result in decreased venous return as well as cardiac output, leading to obstructive shock. Next, we'll discuss the clinical presentation of a pneumothorax. Patients typically present with a chief complaint of sudden onset of dyspnea, pleuritic chest pain, or shoulder pain. Since the pneumothorax is often unilateral, the pain is felt on the affected side. History may reveal clues to the etiology of a pneumothorax, such as preceding trauma, medical procedures, or past medical history of a known underlying lung disease such as COPD. On physical examination, the vitals may show tachypnea, tachycardia. In severe cases, the patient may become hypoxic. On respiratory exam, patients have decreased air entry on the affected side and hyperresonance or percussion. Findings on examination that are indicative of tension pneumothorax include severe hypoxia, hypotension, elevated jugular venous pressure, tachycardia, and tracheal deviation. A pneumothorax can be diagnosed on chest X-ray, CT scan of the chest, or ultrasonography. Often, an upright chest X-ray with inspiratory or expiratory views is the only modality required for diagnosis. However, a chest CT is sometimes performed in more complicated cases such as trauma, recurrence of a pneumothorax in a patient with a previous surgery, or secondary pneumothorax. Ultrasound is also an effective method to diagnose pneumothorax. It's often utilized as a bedside imaging modality to evaluate for procedure-related pneumothorax, such as thoracocentesis, central venous access, post-transbronchial lung biopsy. It's also used during trauma setting as extended phase assessment. Findings on chest X-ray include visible visceral pleural edge marked by the iris shown on the chest X-ray provided in this slide. Peripheral to the visceral pleura, there is an absence of lung markings, which on the X-ray appears as a radiolucent or simply more black. In some cases, you may see a complete collapse of the lung. The key feature on the chest X-ray indicative of tension pneumothorax is contralateral mediastinal shift. Other findings that might be seen on the radiograph are depression of the hemidiaphragm and ipsilateral increase in intercostal space. Pneumothorax size can be estimated on the chest X-ray by measuring the distance from the apex of the lung to the top margin of the visceral pleura on the upright chest radiograph. If the distance is less than 3 cm, the pneumothorax is considered small. If the distance is larger than 3 cm, it's classified as a large pneumothorax. Estimating the size of a pneumothorax is helpful in guiding the treatment. Initial management of a pneumothorax should focus on the assessment and stabilization of airway, breathing, and circulation. It's also critical to determine whether there are signs of a tension pneumothorax, such as hypoxia, hypotension, tachycardia, and tracheal deviation. If tension pneumothorax is suspected, it must be relieved immediately with a needle decompression followed by chest tube insertion. Needle decompression is performed using 16 to 18 gauge needle. The landmark is either the second intercostal space mid-clavicular line or fourth or fifth intercostal space mid-axillary line as recommended by the new ATLS guidelines. Either landmark is acceptable. Needle decompression must always be followed by chest tube insertion. A chest tube is inserted under sterile conditions using 20 to 28 French size catheter. The landmark is the fourth or fifth intercostal space mid-axillary line usually. The steps involved in the insertion of a chest tube will be discussed at the end of this presentation. Once the tension etiology has been ruled out, the next steps of management will depend on the size of the pneumothorax and patient symptoms. For example, a simple apical pneumothorax in asymptomatic patient may not require any intervention, while a larger pneumothorax, where visceral pleura is off the apex and lateral chest wall, would require a chest tube. If the defect in chest wall is large, resulting in a sucking mechanism, then a 3-sided occlusive dressing, often with a zero form, should be used. 3 of the 4 sides will be secured to allow opening for air to escape. This is critical to leave one side of the dressing open to prevent development of a tension pneumothorax. A chest tube is inserted through a separate incision. Treatment of spontaneous pneumothorax can be divided into immediate and definitive management. Options for immediate management include observation, catheter aspiration, or chest tube insertion. However, catheter aspiration is not commonly used in practice. Observation is appropriate for small subsets of stable patients who present with their first sign of a small primary spontaneous pneumothorax with mild symptoms. These patients should be observed for a minimum of 6 hours, followed by a repeat chest X-ray. If there is no progression of the pneumothorax, the patient can be discharged home with instruction to return to care if symptoms worsen. It's important to note that observation is only acceptable for patients who have access to medical services. For instance, if a patient is seeking care from a remote area, an intervention such as chest tube would be more appropriate. A chest tube is required for majority of patients. Chest tube insertion is usually a safe procedure that can be inserted at bedside. The tube is placed in the pleural cavity to re-expand the lung. Once air leak stops and the lung is fully re-expanded on chest X-ray, the chest tube can be removed. Indication for surgical management include first episode of spontaneous pneumothorax with one of the following: tension, secondary, prolonged air leak more than 48 hours, non-re-expansion of the chest with chest tube, bilateral hemopneumothorax, lack of access to healthcare facilities, another surgical indication, or any recurrent episode of spontaneous pneumothorax. Surgical management is also indicated in patients with high-risk occupations or hobbies, such as airline pilots and deep-sea divers. Surgery is done via video-assisted thoracoscopic surgery, in short they call it VATS. It involves the resection of subpleural polyps or ruptured bullae, as well as pleurectomy, which causes pleural fusion. Surgical management reduces the chance of recurrence of a pneumothorax. Chemical fluoridesis is usually reserved for patients who are poor surgical candidates. It involves the injection of a chemical irritant into the pleural space to induce fibrosis and adhesion. Numerous chemical irritants have been used to induce fluoridesis, such as talc, tetracycline, doxycycline, iodopovidone, pleomycin, erythromycin, fluorouracil, autologous blood, doxorubicin, and others. Finally, we will discuss the steps involved in inserting a chest tube. The procedure begins with the proper positioning of the patient on their back with their ipsilateral arm extended and abducted as far as possible. When possible, sedation should be administered. The chest is then widely prepped with a sterile solution and draped so that the lateral chest is exposed. The chest tube will be inserted into the fourth or fifth intercostal space in the mid to anterior axillary line. Freezing is injected into the skin, into the periosteum of the rib, as well as the pleura. Next, a scalpel is used to create a transverse skin incision, just large enough to allow the passage of the tube and one finger together. This incision is carried down through the subcutaneous fat. Then a blunt Kelly clamp is used to divide the intercostal muscles, and then very carefully and in a controlled fashion, a pump into the pleural cavity with a Kelly clamp. As the neurovascular bundle runs on the inferior portion of the rib, it's crucial that the tube is inserted on the superior border of the lower rib to avoid injuring the neurovascular bundle. Keep in mind that the heart, lungs, and diaphragm are often surprisingly close to where you are entering the chest and can be injured during this step. Next, remove the Kelly and insert your finger, feeling in a 360 degree to ensure you are within the chest and there are no adhesions of the lung to the chest wall. You should be able to feel a smooth surface on the inside of the ribs, which is the parietal pleura. If you cannot feel this, you are most likely not yet in the chest and you therefore not ready to insert the tube. You can usually also feel the diaphragm inferiorly and possibly the lung medially, which gives you another clue to your success entry into the chest. When you are sure that you are truly in the chest, you are ready to insert the tube. Place the fenestrated end of the chest tube within a Kelly clamp and use the clamp to guide the tube into the opening in the chest. Once inside, open the clamp, feed the tube toward the apex of the chest, insert gently until you feel resistance. Check the marking on the tube to record the length of the tube inside the chest and to make sure the last fenestration is inside the chest cavity, otherwise the tube won't function. Suture the tube to the skin and connect it to an underwater seal device. Dispose all of your sharps in a safe manner. Finally, obtain a chest X-ray to ensure adequate placement and to assess for any immediate complications. After insertion of a chest tube, secure it with a suture, such as 1 or 2 silk or other non-absorbent sutures. Then connect it to underwater seal device such as vac drainage system and apply dressing. Tape the gauze and tube in place and tape together the tubing connections. In this podcast, we have covered the definition, pathophysiology, causes, diagnosis, and treatment of a pneumothorax. Remember, a pneumothorax is the presence of air within the pleural space with associated collapse of the lung. A pneumothorax can happen spontaneously from trauma or iatrogenic injury. In any case, pneumothorax may be simple, without a major impact on the patient physiology, or tension, which may result in respiratory distress, shock, or eventually death. A tension pneumothorax must be immediately recognized and treated with needle decompression. The ultimate treatment for all types of a pneumothorax is chest tube insertion in the 4th or 5th intercostal space in the mid to anterior axillary line. Armed with the knowledge of the causes and presentation of a pneumothorax as well as the ability to rapidly treat them, you'll be ready to save the lives of patients with this common and dangerous condition.